was happy with that.
Hey, Kale,
Wow.
are you gonna do
She
your
wasn't,
report?
no matter what they
I'll
did,
just
she wouldn't
move
do
the
it.
slides for if you need me to.
He does put a note in here. They
Good morning, everybody. Welcome to the August EMS audit review. As you can see on the screen, the agenda's there. We're going to start our presentation with our preliminary report, and we'll move on through. Got a couple things I need to talk to you guys about in addition to that, but we'll start with Brenda. Yep, you can stand right there in the corner. It's fine.
Cheryl red eye X on her.
Yeah. Should work. I just fixed it. Let me double check.
Good morning, I'm Brenda Williams. I'm the nursing care manager of 2 East Day, and I'm also the chest pain coordinator. Get right into our STEMI report. So this EMS run started at 2:15 in the afternoon. They were dispatched via 911 to a home with a female possibly having a heart attack or stroke. By 18 after, the crew arrived with the fire department to find a 74-year-old woman sitting on the couch in distress. Patient was pale and extremely diaphoretic. She states 30 minutes prior, she developed sudden onset of chest pain and decided to call 911 when her arms were numb. Current complaint of burning and tingling sensation in both arms and severe pain in the left side of the chest. By 14:19, first attempt to get 12 lead. The patient moving around was causing artifact. Based on visual appearance, decision was made for a rapid movement to ambulance where patient was dried off and 12 lead was obtained. By 25 after, 12 lead EKG showing ST elevation in leads 2, 3, AVF, and V6 with depressions in V through 1 through 3. Inferior stimulus suspected. Her vital signs, blood pressure was 114/66, pulse 52, respirations 22. She was 98% on room air. She rated her pain at an 8 on a 1 to 10 scale. IHRM was called in to UH with STEMI alert. By 32 after, patient was given 481 milligram aspirins to chew and swallow, which is gross, and 1 nitrous sublingual after conferring medications and allergies. 20 gauge IV was established in her left AC and 500 normal saline was started. By 2003, rating pain 7 on a 1 to 10 scale, morphine 5 milligrams, IV push was administered. By 14:41, Zofran 4 milligrams was administered for via IV push due to nausea. It's always kind of iffy, so I give a range between 244 and 249. Patient remained conscious throughout the transport. Although she did become more lethargic, her heart rate, blood pressure continued to decrease of 72/30, heart rate of 42. Her pain was maintained at 7/8 out of 10. The patient condition steadily deteriorated with no interventions. By 14:50, they arrived at Union and transferred her via draw sheet to a bed. Report was given to the RN and doctor who happened to be at bedside. Blood pressure was 63/25 on arrival. She was given 1 liter fluid bolus, improving her blood pressure to 96/53. She was also given fentanyl for pain. And there was a note that in the field, they thought about getting fentanyl, but the patient didn't know herself what her allergies were. At this point, they must have figured it out. Patient has prior medical history of AAA, COPD, hypertension, and PVD, and she's a current smoker. By 3:02, cath lab was unavailable, so the cardiologist notified and agreed with the cardiac catheterization. The ER finally got her down there. Patient arrived in the procedure room at 3:45 p.m. Balloon catheter advanced to the target vessel by 3:52. Her stent advanced to the target vessel by 3:56. There was severe coronary artery disease involving the right coronary artery, 100% occluded, and the acute marginal branch with a 90 to 95% stenosis to the ostium is successfully stented with a drug-eluting stent. And even with the delay, the door to balloon time was 62 minutes, so that was still within our time frame. Good run. And there's the summary of our door to balloon times. We did have it slough off a little bit in April and May, 86% in April, 83% in May, but we are still standing at 91%, and our goal is to stay 90% or better. So we're looking pretty good. And thank you for everything you do.
Thanks, Brenda. Thank you very much for the report. Appreciate it. Up next is going to be Beth Harrison. So she's perfect timing.
It's very rainy outside. We heard it thunder a lot.
Good morning, everybody.
This one works.
Okay, sounds good.
Yep. Thank you.
You're welcome. Hope you're all doing well and staying dry today. This is a story of JP. She's a 45-year-old female. She was working an overnight shift south of town, like pretty far south. And she was found down by a coworker at 01:35 in the break room with slurred speech and left facial droop. The patient also complained of a headache and left-sided weakness at that time. EMS was notified at 01:43. The dispatch 01:45, unit was notified at 01:46. They were on the scene at 1:58, left scene at 2:11, and arrived at Union at 2:27. 02:27, sorry. The EMS assessment showed that she did have a positive stroke scale. They did a glucose, was 105, which is great because she did have a history of diabetes and it could have easily been a stroke mimic, but her glucose was fine. Her coma scale was 15, her O2 sat was 97. She did have 2 focal seizures en route, and she was treated by EMS as a stroke. Her prior medical history was she did have a CVA last October, does have a history of seizures, very heavy smokers, current methamphetamine use, and she's currently in an outpatient treatment through the Hamilton Center for Substance Abuse. Brought to the hospital, her NIH stroke scale was 11 on arrival, which is very high. CT of the head was completed at 02:46. She went directly from CART to CT. Our policy shows, did a good job with that. There was no bleed. And the doctor did speak to her and she chose TPA, and that was administered at 03:04. We had a total door to needle time of 37 minutes, which isn't bad. You know, we try to get that 30, but 37 minutes is really pretty quick for a TPA patient. After that, she was admitted to ICU for post-TPA administration care. When she went to the ICU, her NIH was still 7. So we did take her down per our protocol, because anyone who comes in with stroke symptoms or NIH greater than 6, we do a CTA to look for that large vessel occlusion. And if we need to go ahead and look further, we'll do, the CTP if we think there is a large vessel occlusion to see if there's any salvageable brain in there. On her scan, there was no LVO present. And at noon the next day, her MRI was completed and it did not show a stroke. Now, is it possible to still have a stroke and been TPA'd and it should not show up on the MRI? Yes, it is. But she probably was not a stroke. She continued to exhibit stroke behavior in the ICU and on the stroke unit. So I did get a behavioral health consult, and they diagnosed her with adjustment disorder. So we did do a lot of medications adjustment, and her disposition was we sent her to Club Soda, outpatient follow-up. And we found out there that she was not taking her medications at Club Soda because apparently they have a policy at their facility where they can't take those type of drugs. So we did speak with them, made arrangements for her to receive her medications, and hopefully prevent this from happening in the future. So I think that was going to help her a lot. What I really want to look at here are our wins and opportunities. Even though this lady did not code out as a stroke, we absolutely did everything perfect. EMS, she looked like a stroke. She had everything that showed a stroke. The same thing in ER, no bleed on the CT. So we moved forward and treated the stroke. That is absolutely the right thing to do. You'll go to a conference, the first thing they will tell you, you're not TPAing some conversion disorders, some adjustment disorders, you're not TPAing enough. Because you're basing the TPA and your stroke care on what you're seeing at that minute. You don't always know all their psych background. We have a few that come in with conversion disorders, and we know them. We know that we don't TPA them anymore because we're familiar with them. But they did everything right. Her EMS care, the TPA, the hospital care, everything was excellent based on the patient's presentation. And then another one was we got her connected with the proper outpatient psychiatric services. So, maybe save her in the long run. The only thing we could have done different, there was no stroke alert documented that it was called to the ER. And they had time because they were coming all the way from the south of town. And there was no pain score. So those are 2 things we could have improved on. I pulled everything.
Well, I was just wondering what do you mean by the no stroke alert call?
Usually when it's a stroke alert call, I usually see it in documentation somewhere. I go through all the documentation.
You didn't call it as a stroke alert?
No, EMS
EMS
did.
did
Oh,
call it
okay.
a stroke
Yeah.
alert.
Okay.
Yeah. EMS did not. So, usually they're really pretty good at it.
They
but-
almost, I bet it just get, because if we sent her straight to CT from the cot, we called it a stroke alert.
Yeah, but it didn't get documented. So
I was gonna say, I bet it just didn't get documented for
And
us to
she
have
did
the
have
heads
2
up.
strokes. She did have 2 seizures en route, and she was treated for that. But, I would have thought stroke too, because a lot of times with a stroke, you present with seizures
Oh,
afterwards.
every bit of it.
So I think we did a great job, but I just wanted to, look at this case. It's kind of interesting that even though she's not a stroke, we did everything right.
Isn't a seizure a contraindication for
No,
TPA?
it's not anymore. That is an old thing.
Oh, is that still in our policy though?
It should not be. But no, a seizure is no longer, because it used to be, that used to be a contraindication, a hard stop. It is no longer. Because they changed all of those, was it 2019? They changed all the TPA. So that's not, and it used to be like NIH of greater than 20 was a hard stop, you could not TPA, and now that's no longer true either. Basically, they're telling you TPA is their chance. And then there's a lot of documentation out there. Do you TPA or you take them directly to an IR suite if you got that available? So I think we're going to see a lot of changes come in the stroke world, but right now our best bet is to get them TPA as quick as possible.
For the van score, it says that they were a negative stroke scale on the other
No,
side.
so they were stroke scale. They did the Cincinnati stroke scale.
Oh,
but
okay, I was
they
gonna
did-
say, which one did they use? Okay.
But the
They didn't
Cincinnati does
answer
not
the
show an
question.
L,
They showed
right.
an answer.
doesn't always show up, but the NIH of 11, they probably figured it was positive, It's amazing how these psych patients can really mimic a stroke.
So it's possible that they call a stroke alert and then they just didn't document it that way. Okay.
Possible.
I'd have to listen to the IR to see.
Right, and I did not do that. I just looked, this is what I found documented in the chart.
Sure.
But I think they gave great care. She was treated, her seizures were treated appropriately en route, and she got great treatment here in the ambulance.
Good.
So, if you guys have any questions about our stroke program, let me know and I can answer.
I appreciate it. So our next, yeah. Whoa, wait, wait. Hang on a minute. No idea why that's doing.
You really want to
We're
get
in yours.
Goodness gracious.
You're all over.
Wow. Hold on a minute.
He's just not used to all these people.
Yeah. Kind of got ugly, didn't it? It's gonna look great on the video. You gotta be kidding. I just changed that. Okay, here we go. KO, are you there?
I am good, sir.
All right.
Good morning from all your friends up north here, and thank you, Barry, for manning the button for me. My name's Cale Stewart. I'm the clinical educator up here at UHC. I apologize for not partaking down there with you all, but I've got a new travel nurse that I got to spend the remainder of my day with. So thank you, Barry, for making this happen via Zoom for me. To kind of tag along on what Beth was saying there, I assist with both our chest pain accreditation and our stroke ready designation. So this first case here is representative of our local EMS agencies up here in Park and Vermilion counties. This case one is a 63-year-old female with a prior history of COPD, non-insulin dependent diabetes, smoking, AFib, hypertension, all of the common modifiable risk factors that we see up here in the north end of the care area. She actually called 911 herself due to her self-perceived, her subjective facial droop and difficulty speaking. And then on the next slide, we'll actually see the run history per the EMS report. They received the call at 3:25. Due to proximity, they were actually on scene at 3:29. kind of an extended scene time there. They were on scene for about 17 minutes, departed the scene at 3:46, and arrived here at the emergency department at 4:05. And then on the following slide, we'll see a slightly edited but copied and pasted run report from the actual EMS run. And there was a little bit of difficulty getting her up from the sofa to the stretcher. And then they actually found some marked hypertension. They then contacted the UHC medical control. They spoke to the ER physician via the radio, questioning whether or not they should actually give her some labetalol for her hypertension. If I recall correctly, I'm talking like 230s over 110s or something like that. The ER physician at the time declined. He wanted to further assess the patient. And then upon arrival here, they actually escorted the patient over to the CT suite due to high census, high acuity in the emergency department alongside the RN, and then back to a patient room. And then on the following slide, we'll see the care and disposition of the patient here in the emergency department. Thanks to EMS's escort over to the CT room, which isn't unheard of. They do this all the time. We got our CT head. It was negative within 10 minutes from presentation. The patient was ruled not a TPA candidate via the emergency room physician and teleneurology due to those minimal resolving symptoms and a low NIH. Patient did get a CTA head and neck that displayed bilateral 50% stenosis of her carotids. Incidentally, we found a UTI in conjunction with teleneuro. The emergency room physician diagnosed her with a TIA, and then that patient was admitted here and then discharged home, improved in a couple of days. On the following slide, we'll see some of the highlights and opportunities that we saw. Kind of, again, tagging on to what Beth saw and mentioned. We had great documentation from this EMS crew. They had recognized a stroke, called it as a stroke. And then, as I mentioned just a second ago, EMS actually accompanied the RN to the CT suite due to acuity and, again, census in the department, and then helped transport that patient back to a patient room. Again, that's not unheard of. We have a great working relationship with our EMS crews up here. Case study 2, representative of the other agency that we see up here at UHC. This was a 67-year-old male with a lengthy cardiac history, as you can see there. He was awoken in the wee hours of the morning, I think it was like 1:32 in the morning, due to sudden onset of chest pain. Woke his wife up. They tried to drive to the hospital, but wound up calling 911 from a local parking lot due to worsening symptoms and increased pain. On the following slide, we'll see the times listed by EMS from the run report. They received that 911 call from the parking lot at 2:14. Again, due to proximity, EMS was on the scene at 2:16, departed the scene at 2:18, and they were right here at 2:30, about an hour, hour and a half after symptom onset. Here we have a capture from the EMS report showing the patient's care en route, details how the patient's symptoms worsened, how he was a hot mess. They gave him some aspirin, which is awesome. And then at the bottom of particular note, this was a BLS run due to a paramedic level care not being available due to high call volume at the time. Unfortunately, we do see this up here at UHC. When the paramedic unit trucks are out, we will take all comers. This unit appropriately and rightfully so came here to Clinton as opposed to heading down to the main campus just due to the patient's condition and need for stabilization. On the next slide, we'll see some of that. Upon arrival here, that patient received an EKG, and the emergency room physician called that a STEMI within 5 minutes. We have a one-call STEMI process where we notified the Terre Haute Emergency Department. That one call was made. The Terre Haute Emergency Department then notifies the cath lab, makes those calls in, because again, this is the wee hours of the morning. And we actually had a door in, door out, thanks to EMS, of 26 minutes with this STEMI patient. Highlights and opportunities, I just mentioned it, but there was no paramedic available, but that BLS unit appropriately and correctly stopped here for stabilization of that patient. Another highlight, because we had a prompt diagnosis of STEMI within that 5 minutes, the EMS unit was still here, and we actually threw a nurse in the back of the truck and transported that patient down to PCI Superstat. Years ago, we used to do that all the time. I've ridden in the back of an ambulance dozens, if not 100 times in my years working nights, weekends in the emergency department. But to still have that availability of that EMS unit on hand and willing and ready to take that patient is amazing care for our patient population. That's all I got from UHC. Any questions from y'all?
Cale, thank you very much. Appreciate it. Great idea on the RN accompanying. That's kind of cool. It's good to see this still going on. I know that happened a long time ago when we were younger. So,
Absolutely.
our next up is our trauma report with Tina. She's so excited. I'm pretty sure she's really excited. It'll be new for her, for us.
I will. All right, how you work this thing?
There you go.
Okay. There we go. All right.
Yep.
I am Tina Hedges. I'm the performance improvement nurse for trauma now. This case is from it's from May. It was a 17-year-old female. Do you remember, were there 3 people in the car?
I think 4 total.
Was it 3 or 4?
3 came here.
Yeah. But the focus is for this patient. It was a motor vehicle crash. 911 was called at 22:51, dispatched 23:02, en route 23:04. They were on the scene at 23:13. I think fire department was already there and had used tools to get the door open, so they were ready for them. They left the scene at 23:25, and they were at the emergency room here at Union at 23:36.
Do you need to speak up a little bit? I've got a text message.
Oh, okay, thanks. Times, I've never heard that before. Times call to dispatch was 11 minutes. Dispatch to en route was 2. En route to arrival on scene was 9 minutes. On scene to departure was 12 minutes, which was really good for as serious as everything was. Departure to arrival in the ER was 11 minutes. Total time was 45 minutes. So first, this was a level 2 activation. Per the EMS report, the patient was a restrained passenger of the SUV with right side damage. Extrication tools were used to open the door. Passenger side impact, it was front intrusion. They said in the documentation they couldn't tell how far because they already had the door open. I'm guessing that kind of shoves things back. Approximate speed was 40 miles an hour. Said in their report that seatbelt, there was seatbelt use and airbag deployment. This patient had no past medical history, and at the time of their arrival, she was denying neck or back pain. All right, and she was complaining of difficulty breathing, left ankle pain, left or right upper quadrant pain, pelvic pain on pressure. She did have an obvious deformity to her left ankle. She was lifted out of the car. They said when they first tried to get her out, she was screaming because of the pain. So firefighter got in the car on the other side and helped to lift her out. They placed her on a backboard and carried her to the cot. At that time, she was in sinus tach. She was hypotensive. There was a question about whether they could really get the pressure because it was so noisy at the scene. She was dusky, her lips were cyanotic. She had bruising to her left breast, right upper abdomen, right upper leg. She had decreased breath sounds on the right. When they did get vitals, her pressure was 90 pound. Heart rate was 155, rest 28. Her GCS was 14, SAT was 86, 75, and 94, and that was through the whole run. They started 2 IVs, put a split on her left lower extremity. They did do a needle compression to the right lung because they determined that she did have a pneumo. They didn't get any air rush back, so they just left the needle in place and left. They had her on O2 non-rebreather. and their documentation that the C-color was placed prior to them exiting the unit once she got to Union. All right, what types of injury do you look at or look for with a side impact? Shoulder injuries, pelvic injuries, chest injuries, especially ribs and lungs, fractures, internal hemorrhages, organ damage, traumatic brain injury, spinal cord injury, and the emotional injuries that go along with that. As you'll see, she had pretty much all of those.
Yeah.
So she got to the emergency room at 2342. It was upgraded to a level 1 very quickly at 2344. The assessment findings in the emergency room is that she was tachy, pale, diaphoretic. She had pelvic tenderness on palpation. The FAST was done and showed free fluid in the right upper quadrant and blood in the suprapubic window. She did have a left ankle deformity. She was somnolent but aroused easily at first. She quickly became unresponsive after arrival. Blood pressure has a 183/, that's what was documented. She was documented hypertensive with the diastolic in mid 100s for about 18 minutes. Then she became hypotensive again, so I can't say for sure those readings were accurate, but there was consistent readings that were high. Then she went down to 81/57. She remained hypoxic, tachycardic. The best reading that they got during her stay in the ER was 118/70, 108, 25, 100% on the vent. That was with her being on the vent, and 2 chest tubes. So diagnostic, she had a CT of the head, CT of the spine, L-spine, T-spine, CT of the chest, abdomen, pelvis, chest x-ray, and x-ray of the pelvis. And I'm not gonna go word for word all these. She had multiple serious injuries because there were so many of them. She had a comminuted fracture of the right occipital condyle, am I saying that right? With mild posterior and displacement of the condylar fragment. Basically, she had a slight rightward subluxation C1, C2, fracture of the lateral medial aspect of the right first rib, acute fracture of the posterior medial aspect, second rib at the costovertebral junction, extensive subcutaneous emphysema along the neck and upper chest. Some of it went into the epidural region through the neuroforamen into the cervical spine. She had partially visualized pneumomediastinum at the thoracic inlet, bilateral pneumothorax, and it goes on. Acute right L2 through L4 transverse process fractures, acute L4, L5, S1, S2 spinous process fractures, comminuted vertical fracture through the left upper sacrum, extending into the midline of the mid-sacrum. Right chest tube wasn't in good position. When she got here, the emergency room physician put in, I believe it was the right chest tube. The surgeon, trauma surgeon, I think it was Luking, put in the left. The right chest tube was replaced. So anyhow, she still had a pretty good size right pneumothorax. The left chest tube was in good place and showed just small residual pneumo. She had bilateral atelectasis and pulmonary contusions. There we go. Grade 4 liver injury, grade 3 splenic injury with small amount of hemoperitoneum in the abdomen and pelvis. Right lateral 2nd through 7th rib fractures, but the 6th and 7th were mildly displaced. And again, the subcutaneous emphysema that went into the upper abdomen. Multiple acute pelvic fractures with extraperitoneal hemorrhage in the pelvis related to the multiple pelvic fractures. And of course, flattening the IVC because she was of her blood loss. So in the ER, she got antibiotics. She had 2 chest tubes, actually 3, if you count the one that was replaced. MTV was activated, TXA times 2. She was intubated, put on the vent. So of course, she had all these serious multiple injuries. She was transferred to Method CD because if things weren't bad enough, the weather was terrible and they couldn't fly. So she had gotten, I can't remember, 7 to 9 units of blood total in the emergency room. And then we sent
We finally decided.
Yeah, because we had to count, which was one of our opportunities for improvement. We sent 4 units with them because they were so concerned that she would continue to bleed on the way up there. So total time in the ER was right under a 2-hour window, 1 hour and 57 minutes. So I think that was great. I think the EMS times were really good for all that was going on there. So it's a critical patient with multiple serious injuries. I did look her up. She was at Methodist for 12 days, did discharge home with continued therapy, still wearing a collar and in a wheelchair, but her prognosis for recovery was good. It's just going to be a very long recovery. So did we follow all the protocols for care? Did we do everything we should have? And what were the opportunities for improvement?
Did you say she was the driver or the passenger?
Restrained passenger. Yeah, and there's a question, because when I was looking at IU's notes, they said that she was not.
When
When did she get changed from a level 2 to level 1?
So that was where I was gonna go with that. I think
That's
she
me
probably
too.
should have been level
She
one.
should have been
from the
level 1
get-go.
from the
Yes,
first
First
one.
because she was,
Yeah.
she was shocked no way.
Yeah.
And right there at that scene with those
So what
multiple
was- what do
injuries,
people
they
not
should have
understand
called
about
it
that?
a level 1. So
I think that's an opportunity for.
we are
education for
working on
staff.
that. We've put
Shock.
the posters.
If this
with the-
if this lady's not a level 1, there aren't any level 1.
Exactly, exactly.
So the seat collar was put on, I guess that's. more
That was
reasonable.
the other thing. I wanted to
Why was
ask
it
the
not
EMS
done?
people,
Should
why
it not
would
be
we have
done in
delayed
part?
that?
Okay,
I
thank you.
would think.
All right.
Because I'm not EMS trained, so I don't know what the protocol is, but with them seeing how serious she was, but in my mind, playing the nurse caring for a patient, maybe if I was on site, it was midnight, the weather was really bad, they were on
Really bad weather if I remember
46.
right. Yeah.
They were on 46, so it could have been the scene was unsafe. She was short of breath. Maybe there was concerns about that. But, and that's all fine if you're not gonna follow protocol or policy, but you gotta document it.
So I
That's
get
the only
getting her out
protection
quickly,
you
but I think
have.
she should have at least had a collar on in the car, because the medic climbed in the car with her.
That was, and maybe they were holding traction.
No,
I'm sure they
no,
were, I'm sure they were.
Major stabilization throughout the entire time before, but if they were concerned about intubating, they probably were waiting to put a collar on.
Okay.
But they didn't intubate, obviously, in the field, so, I don't.
And I'm sure in their mind, they had reasons for not doing it.
And this is
My
a
ins-
multiple patient incident. There were 4 kids in the car, I believe.
Yes.
This one's nasty though.
Yeah.
I think the other, we did get
We
another
sent
level 1
another
out of
one
this.
out. One
So there were
stayed,
2
one was
level 1s out of
discharged.
this one. So it was a bad situation.
Yeah,
So
it
it
was
was actually
very
handled
bad.
very well.
Yeah, so my
So
concern was, if you don't do it, document
Yeah,
why you
just-
don't, you know?
Dr. Malamed, were you gonna say something?
Yeah, I think this is actually my patient who
Oh,
came in, and I think as a team we did a fairly great job in-house. Key takeaways just from my perspective: if you do a needle decompression, especially if you look at the research now with needle decompressions in the field, in the old school teaching of the midclavicular line about your second intercostal space is not being as great, especially as our general population body habitus. And she wasn't a big girl to begin with, but a general population body habitus. If you look at most needle decompressions, they're not getting to that space. So you want to consider looking at the anterior axillary line and using that as a space at either the 4th or 5th intercostal. So if you do it and you're really suspicious for it and you're not getting relief or at least improvement in either hypoxia, work of breathing, or your SpO2, you should consider doing a needle decompression at the 4th or 5th intercostal at about the anterior axillary line. And then the other thing, trying to think, really the other big thing for me is ensuring that this is a level 1 from the get-go. Because then it really gets me resources in-house. I placed both chest tubes, had a great gush of air on that right side. And then after the scan, it ended up looks like a tract sub-Q, and Dr. Luking had to place the 3rd chest tube. But no, I think we did great. Obviously the challenge also is ensuring we've got adequate blood supply for the patient to go, especially when they're going by ground. It's a good hour and a half or so. I think with that weather too was challenging too. So I think en route, she got 2 units, if I'm not mistaken, for a total of 9. But I actually saw her in the ED about a month later. She came back as a patient, sadly had pneumonia and a PE and a bunch of other stuff. She's got a long road ahead of her.
So I would like to add, if I can, something is great job. I understand it and how it, for whatever reason, the C collar wasn't put on. That's beside it. One thing for EMS to remember is It is our job to call the trauma alert. It is not our job in the field to say it's a 1, 2, 10, whatever, I don't care. That's on the hospitals, no matter where we go. So always keep that in mind. Do not call the trauma alert. Please let somebody know what you have. I'm sure this was a trauma alert without any issues. I don't think that's been a problem. I just want everybody to understand that is basically our place to do that. So the next presentation actually is going to be me. They had to scrape way to the bottom of the barrel and they picked me out. I'm gonna talk about some lower extremity injuries. Dr. Malama had mentioned this one to me, and ortho was not available, so you're stuck with me for now. Just going to talk about from hips down to our feet. Just different things we're going to talk about, some different pictures, some different things we're talking to go over protocols and stuff. So lower extremity injuries. I'm starting from the hips down, understanding a few things that always keep in mind when we're talking about taking care of injuries like this. Bleeding will happen. The thing is, unless it's an open fracture, you don't know it. Just remember when we're taking care of these patients that bleeding will happen, and hip injuries, thigh injuries, there's a lot of bleeding. You can lose a ton of blood. I mean, you can lose anywhere 25 to 35% of your blood volume. You know, anybody normally carrying 4.5, maybe 5 liters, depending upon the size of the patient. You know, if you're losing, up to 35, you could be losing up to 2 liters of blood in the hip alone, and it'll hold it. Trust me when I tell you, it'll hold it. It'll hurt. There's, understanding blood has some caustic properties to it. So if it's not inside the vessels, it hurts tissue, it burns. So it has a tendency to make people actually hurt even more because they are bleeding into that area, just for space reasons and things like that. So just to give a good picture of what we're talking about. Come on now. Yeah, okay, so we're gonna start with hip fractures, I think, as soon as my stupid thing works.
Oh.
Yeah. Population gets older, which everyone's getting older. I don't like it myself. So hip fractures are very likely. Over 300,000 older patients, 65 and older. More than 95% of hip fractures are caused by falling. I agree with that. And typically, and as you're out in the street and you're taking care of these patients and you're noticing these things, I know this sounds silly and maybe it's not something you think about. Pick up the rugs that are all bunched up that they're tripping over and throw them into the corner. Get them out of the area. Do not allow that opportunity for them to come back in and do it again, because it will happen. They're all wrapped up in their 150 feet of oxygen tubing, or they're all wrapped up by their little dogs or cats, and they're falling and they're breaking their hips. Okay, and they're fracturing their hips. And women experience 3/4 of all this. So that thought about out of 300,000 people, that's a lot. So
I can tell you for us, it's about a 50-50.
is it?
Yeah.
Some different types of descriptions of hip fractures. There are some different ones. I've got a couple of good pictures too. You can have a femoral neck. That's the area of the femoral of the femur below the ball. That's actually the femoral head. That's where it snaps off, and that is actually the bulk of where they're at. Intertrochanteric area, the area below the neck of the femur and above the long part of the shaft. It is called intertrochanteric because it is marked by 2 bony landmarks, and you actually will see those on the description. The greater, and there's the greater and the lesser, and they're one bigger than the other. So there's also the subtrochanteric area, that's the upper part of the shaft of the femur, and below the greater lesser in there. So then the femoral head, another thing where it snaps off and the femoral head stays in the acetabulum. So those are the common types of fractures and neck fractures. So I've got a picture, like I said, pushing this button like a million times and it's just taking forever. So really good picture here to talk about the greater trochanter and the lesser trochanter. And then you can see that part in the middle, that's where the snaps off. It's either going to break off at the femoral neck or in that intertrochanteric area, because those are the parts where people go. And you understand this, it does require quite a significant force. But if you take these patients that are 65 or older and they're smaller, that chance of them landing directly on that bony part sticking out of the hip will snap. It makes it a whole lot easier to snap and break. All right, you take an elderly patient who actually has some osteoporosis and things that maybe they don't know or they do know, greater chances of cracking and breaking the femoral neck off, okay? Wow. I'm afraid to push it twice. So this is a good picture. It shows a good picture of the pelvis, and then you see where it's actually broken off at the femoral neck, right at the head, right below the ball. So you can, and you can't see this, but if you look at right above the areola, that circular portion, that's called the acetabulum. That's where the head of the femur actually sits inside the hip. All right. If they go in and take and do a total hip, they actually create an all new acetabulum, a new femoral head, and a new shaft. And they drill out the femur and they put a new shaft in there basically. And you just basically could get a metal or, you know, a different type, they have plastic, the acetabulum's used in plastic. So in order to repair this, if that's in good shape, all they really have to do is take the head of the femur out. If the acetabulum's still in really good place on this particular one, or they can line it back up correctly and put pins and screws right directly up through the femoral head into the hip. I remember doing this when I was in surgery doing ortho stuff, and it was really one of the coolest things. I always like pieces and parts and putting them back together, you know, so that was kind of fun. But that's a really good picture and how it snapped off. But I do want you to remember, if you're thinking about presentations on hip fractures, which I think is my next. Yeah, so most patients with a hip fracture will present with an injured leg. It's going to be shortened and rotated laterally or outward. So the thought process is very simple. Your thigh muscles are extremely strong. I don't care whose legs you are. They are stronger than what you think they are. And they're really kind of tight. So thinking about this, if I snap the head of the femur off at the neck, I instantly, those muscles are going to pull that leg up. That is one of the reasons why it's shorter. Because literally half of that bone's broke off. Does that make sense? So that's actually going to one of the reasons why the leg will become shortened, and then it's going to rotate it outward, fall outward, because there's nothing holding it. It's now free flowing. It's literally completely not attached to your body. If it wasn't for the skin and the muscles, it literally would fall off. Does that make sense? So the thought process to me is, if you see it shortened and externally rotated or laterally rotated, it is fractured until proven otherwise. For us, we just need to make sure that we take care of our patients the same. You know, if we think it's a dislocation, we're still going to splint and hold that in place so it doesn't move. If we think it's fractured, we're going to splint and hold it in place so it doesn't move. I do not want you to know that the part about the hip dislocation, if the femoral head just pops out, it's still the full length bone. That's why it's going to be longer, and it's going to rotate inward. So it's going to rotate medially. So your foot's going to rotate towards the middle. And so it's going to be longer and rotated inward versus shorter and rotated outward. That's really the best way to tell the difference between a hip fracture and a hip dislocation. Dislocation just means the head of the femur needs to be put back up in the acetabulum. They may have to pin it and keep it there, because if it pops out, I've known some people that they popped out more than one time. So that they'll fix that. But I think the bottom line is the most important thing for us to remember. Anybody with a hip injury is they're going to be in pain. A wise paramedic a long time ago taught me that every bone has the word navel, nerve, artery, vein, kind of an empty space, and then a lymphatic system on each side of the bone. And so there's nerves on every piece of bone that you own. So if you break something, you're going to feel it, right? And if you cut one of those vessels, that's even worse. All right, so the thought process is nerve, artery, vein, and lymphatic systems all run next to every side of the bone. So pain, because there's nerve endings that touch everything. If you're a paramedic and you remember when you were taught to do the needle decompression we were talking about earlier, how we're moving now more anterior lateral, but when we were in the second and third intercostal space, we never put it to the top, we always put it to the bottom, because the nerve sits right directly underneath the bone. And if you hit that with the nerve, it could cause some problems. So the thought process, same concept. If you take that on every bone in your body, they are there. The nerves and the arteries and the veins are sitting right next to the bones, and so that's why it hurts. That's something to always keep in mind. When we are taking care of a patient, so we have a patient who has an unstable pelvis. So you go and you realize that the pelvis is unstable, it wiggles, it moves, it doesn't pressure. You want to apply traction, stabilize that pelvis, and stabilization. There's devices, commercial devices out there, or at least a pelvic sheet wrap. And I've got some pictures to show you. That's generally what we do, because right now the pelvic stabilizers that are on the market are very expensive. They're real expensive. Figures. They're real expensive. Okay. So the thought process is, sheets are cheap. We can get those and reuse them and everything else. So, but the whole idea is to not allow the pelvis or the leg or the hips to move. Because when you move bone against bone or bone against veins and arteries and stuff, the chances of causing more damage is there. So it's really, really important. Okay. And if you're a paramedic and you're an ALS service and you can pain medicine, I would highly recommend giving some pain medicine before you even move the patient. I have done this several times, and I'm sure you all have too. If that patient's laying on the floor and you've got a shortened, rotated leg, I'm going to give that patient some fentanyl before I even move them, to maybe try to relax them and calm them down, to make it a little easier to get them up off the floor and onto the cot. Okay, so that's something just to keep in mind. So there's a couple of different pictures. Y'all see the hip. You know, we got the lady on the backboard. You know, the key is keeping the legs together. and tying the legs together so that they don't move. I don't want any movement in that hip. The hip's unstable. We don't want it moving. We can't. We need it to be solid. And then that's just a pelvic binder that's commercially, but they are pretty expensive still. I thought they might get cheaper over the years, but they're not. And as more of them get made, it will become cheaper, but they're still really expensive. And unfortunately, if I'm an ambulance service and I put that on the patient, I'm never getting that back. Once that's on there, until they go to surgery, they're going to cut that off and then put the patient to sleep, cut it off and work on it anyway. And it's going to be gone. It's the same, 90% of the time you send a traction splint to Indianapolis, you never get your traction splint back. It's the same kind of concept. So. Wow, I'm sorry about that delay. So the next thing down, if you're moving way down, we're going to talk about femurs. Your thigh bone, which is your femur, it's the longest bone, strongest bone in your body. Because of this, it is extremely hard to understand the total amount of force required to break your femur. I mean, it's not just, it requires a massive amount of force to break your femur, okay? Motor vehicle collisions, for example, are probably the #1 cause for femur fractures. And it's basically because you put your feet straight down, and if you get hit from the front or the side, your legs planted stiff, the bone gets hit. I mean, anything can happen. I mean, footballs that happen. I've actually taken a couple of people with soccer, rugby. I've had a couple of guys with fractured, broken femurs from rugby. The long straight part of the femur is actually called the femoral shaft, and that's what usually breaks. When there's a break anywhere along that shaft, it's called a femoral shaft fracture. Pretty simple to deal with and see. So it must always require surgery. Here's some different types of fractures. There's transverse, which is straight across. Oblique, this type of fracture is angled. There's spiral, where it actually creates a spiral looking break in the bone. Comminuted means there's several pieces and parts showing. And then we can have the open fracture. The open fracture is actually the bone sticking through the skin. And we don't left the, as I tell everybody, we're not going to spit on that and put it back where it belongs. We're not going to pull traction or put traction splint on an open fracture. That is contraindicated. All right, and our protocol is contraindicated. We don't do that because we don't want to pull the bone back into the body. We're going to leave it out. We're just going to splint it as is. Make sure we control the bleeding. Okay, which we'll talk about that in a second. So this gives you a decent picture of where the pelvis and where the head of the femur goes into the acetabulum into the hip, and then you have your femoral shaft, where that's a lot of the breaks happen through there. And this is a pretty good picture of a broken femur. And you look at this, and I want you to note in this picture, yeah, it's a femoral shaft break, but most important thing is if you look at the bony edges, the sharp edges of that is dangerous. There's a femoral artery running in there that's really big, and if you cut that femoral artery gets cut, someone's gonna bleed to death about 30, 45 seconds, maybe a minute if you're lucky. And you know what happens with our body, right? If we start bleeding out, our heart rate goes up because it's like, oh man, I got to produce more blood. And then we just bleed out faster. I mean, so it's a defense mechanism that actually works against us instead of for us. But that right there is a perfect example. Also, if you think about the nerves sitting on the edges, look at those two bones are touching, right? Those two bones are touching. So when we're in the field, one of the best ways to fix this problem is manual traction. We're going to pull on that person's leg. All right, we're going to pull on it, and we're going to create, pull the bones apart. And they're going to scream. They're going to scream at you really loud. And as soon as those bones come apart, they're going to stop because the pain's gone. And you'll know when you have the right amount of traction when you pull that apart, because the bones scrape, 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 scream, 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 and it stops. And you just never let go of it then. And then that's when you put the traction splints on and create manual traction, or traction for you by the machine, by the splint than yourself. So there will absolutely most always be deformity noted. Some cases, an open femur fracture, have the bone sticking out, severe pain and tenderness. Once again, if you see this really deformed and you're at a paramedic level, pain medicine ahead of time before you start even doing traction splint could really help you quite a bit too. If you're not at the paramedic level, manual traction is the best thing you could ever do. Get those two bones apart. Don't let them touch. Don't let them rub. And once you get them apart, the traction splint needs to be in place, because I don't want them to move. I need those stabilized. We want our patient to have those stabilized, because if we don't do that, we're going to cut tissue. If we're cutting tissue, remember when I said in the femur, you can hold 1,000 to 1,500 cc's of blood just in your femur. It will bleed. If we continue to make it bleed worse, it's just going to swell. Then we have the potential for compartment syndrome and everything else in there too. So we want to be really, really careful with that. You stabilize that leg. It's probably the most controlled bleeding if you have an open fracture. Applying traction first manually and then by your traction splint device. Do not apply traction to an open fracture. Put that in there, and I mentioned it twice now. It's really important. Literally do not want to put the bone back in the body. All right, it's as simple as that. Pain management at the paramedic level is an absolute must. Also consider pain management before traction. And then I wanted to make a note, if you're at the paramedic level, if there's an open fracture of any kind in our body, our protocols show antibiotics, okay? And I've got it in the protocol show you when talking about, that is hugely helpful for any trauma center. I don't care where it is. If we can get the antibiotics in, what do you have, an hour?
60 minutes from.
If 60 minutes from the time,
Injury.
from the injury, 60 minutes from the injury. So if we can actually do it in the field and route to the hospital, we're saving the ER and getting the antibiotics on board for our patient faster. And so I wanted to mention that at the paramedic level. EMR levels, it's stabilization and control bleeding. EMT levels, same thing. Pulling track, get a traction splint on those. Stabilization is probably the key. And this is just a good fracture, a good normal old. They got some different ones now. I just found a couple pictures to show. Once you pull manual traction on the foot and you're pulling the legs apart, you get the two bones apart. That traction splint that's on the screen then holds it in place for you. It does all the work. Understand this, you're probably going to have them on a backboard just for that. And it may require an extra long splint on there because the traction splint may be too far. The reason you put them on a backboard is two reasons. One, you want to be able to pull them higher up on the cot so that their leg will actually fit in the cot. Because we've had some long, taller patients with broken femurs, and we've had to pull them all the way up on the cot so the doors would shut, because that's how far you have to stretch the manual with the traction splint. So just the thought process is, and well, I mean, we're not a fan of backboards anymore because the poor skin integrity, what it does to skin, even in the short 15-20-minute drive. We don't want backboards, but we may be required to have one on this. May not have to have a backboard, but you're definitely going to have a long splint or something for that traction splint to sit on and be held steady to. And it may require an extra set of hands just holding the leg still in the back of the ambulance. And there's nothing wrong with that. If that's what it takes to grab an extra set of hands. So granted, we have a lot of problems with extra hands and don't know if we have enough. So moving on down the leg, we're going to talk about tibia fractures. I didn't put tib fibs in here both. I have some pictures of both of them, but I didn't put them both in here. I specifically just stayed with the tibia. It's the largest bone of the two. All right. I thought this interesting though. Incidence of open fractures of long bones is estimated to 11.5 out of every 100,000 people. 40% occurring in the lower limb. Very accessible to get beat up. I mean, it's very simple. We just had one over the weekend, a lady had bilateral open tib fibs, right? So it literally can happen. So most common fracture of the lower limb occurs at the tibial diaphysis, which is the long portion of the tibia, the big portion of it, okay? Tibia fractures are the most common lower extremity fractures in children. They account for 10 to 15% of all pediatric fractures. Again, thinking about your thigh, I think that the muscles are very protective. There's not a whole lot of muscles in the front of your leg. If you really reach down and touch your leg right now, you're touching straight skin, maybe a little bit of adipose tissue, and then the bone. The calf is behind it. It protects it from behind, but doesn't protect it from the shin bone in the front, right? I mean, people don't hit your shin like, oh man, that really hurt. Well, it does. And thinking about what it takes to break one, though, is a little bit more force. So just a thought process. Of course, there's different types of tib fractures. Okay, you've got transverse, you've got oblique. Spiral fractures, again, the comminuted is multiple pieces. That's a bone that's broken in two or more pieces in two or more places. And then, of course, we have the open fracture where the bones are sticking out. Again, stabilization and less movement. And I want to bring back, I haven't mentioned this in the other, for the hips and the femur, but I will bring it in this. Applying ice packs or cold packs to this area is really a really good idea. And two reasons. One, of course, it helps reduce swelling. And if the swelling is gone, the pain reduces. That's as simple as that. Two, it helps slow down any bleeding. It literally will help do that. So the thought process is keeping those areas with ice packs is a really good idea. It will help protect the legs. It'll help protect the swelling, and we want the swelling to go down. Your body's defense is to send tons and tons of blood there and fluid there to help eat all the bad stuff and fix the swelling, but it creates swelling, and we want that swelling reduced because that swelling just puts pressure on the nerves and it makes everything hurt. So we want that to slow down. So doing ice packs and stabilization of the injury is probably one of the best things we can do, even at whatever level. It doesn't make a difference. So just a good picture of the tib fib and how much bigger the tib is than the fib actually. So you will have deformity noted, pain and tenderness to that portion. There will be swelling, as I mentioned before, and then open fracture is always possible. Once again, if you have an open fracture at the paramedic level, please give that antibiotics we have on thing, and it's in the protocol, I've got it up here, so. Splinting, very, very important. Best thing you could ever do at any level, EMR all the way through paramedic, is splinting that and reducing movement. We need it to not move. If we don't move, the bones don't move. And if the bones don't move, the pain is way better, more tolerated that way. And if a patient's less pain, they have less blood pressure goes down, the heart rate goes down, because all of those are in conjunction. If they're in pain, all those numbers are going to go up. If they're in pain, and you see the pain and the numbers aren't going up, there's a whole nother issue going on. So the thought process is in conjunction with everything you're doing. Ice packs, pain management at the paramedic level, open fracture again with the antibiotic treatment at the paramedic level. That's a pretty nasty break.
Hey, Barry.
Both bones comminuted. Matt, go ahead.
Can I interject this is fantastic. I just want to interject two quick things. If you're, what we used to be taught, and I think still fairly holds true, if you're looking at the patient, you're like, why is this patient hypotensive? And you're not seeing blood on the street, on the gowns, and there's no giant hole somewhere. Think of a couple things, right? So it's either a broken femur, it's their pelvis, or it's intra-abdominally. And if you think about those three things, right, remember that if it's a pelvis, we're going to do a binder or a sheet, whichever one is most, and they're all perfectly fine. If it's a femur, obviously, you'll see the probable deformity there. And then if not, it's intra-abdominally. So always think about those three things, especially when you're seeing it and say, well, could it be the pelvis? And it used to be that they teach you to squeeze that pelvis and see if there's a pelvic rock. We try and kind of avoid that because that ends up causing more shear damage and probably more, bleeding from that vascular bed. So once you notice some pain anywhere, just do that once and call it. You don't rock it, just, palpate for pain. And really little tenderness pain is their report, but palpate for tenderness. And then once you've determined that, just put a pelvic binder on it. You're not going to really hurt them if you're wrong. So totally great to do that.
Okay. Thank you very much. So it's a pretty decent picture of a comminuted fracture of the both tib fib, multiple pieces, different breaks. That's an orthopedic fun day for somebody right there. So this is an open fracture. Once again, this is one where we're controlling bleeding, okay? This is also the one where if you're paramedic, this needs pain medicine and cephalacin. All right, that's what we carry. That's what we need to be able to put on for patients. That's a pretty decent break. And you'll notice how the foot's really rotated. That's broke. There's nothing holding the foot back on the end of the leg. All right, the end of the leg actually stops about mid shaft of the calf, right? That because it's broke right there. That broke both ways, so that makes a difference. And splinting, using the same splint, board splints, you can splint with the knee bent, you can splint the knee with the leg straight. It really doesn't make a difference how you do it as long as it's splinted and you got pulses before, pulses after. If you don't have pulses with it, and I'll show you in our protocol what it tells us to do that. So I'm going to move on to ankles now because just quickly get into this. I don't want to keep you guys too long. So broken ankle is also known as an ankle fracture. Once again, hey, remember this too. If you're calling in a report and you're taking care of your patient, calling in a report, if you have deformity noted, please note that. Tell them this is deformity noted. Don't tell them you have an ankle fracture. Don't tell them you have a tib fib fracture. You can tell them that there's deformity noted or bleeding noted or something like that because we don't have our x-ray vision in the back of the trucks, but we do have x-ray vision here at the hospital. All right, so the thought process is we're going to make sure we let everybody know there's deformity noted, bleeding noted, whatever the case is, but we're not saying that it's a broken leg or a broken whatever. So fracture ankle can range from a simple break, which may not stop from walking, to several fractures, which forces your ankle out of place and could be, then I've seen multiple dislocations and fractures at the same time. It's just pretty nasty thing. So more bones that are broken, the more unstable the ankle will become. They classify ankle fractures according to the area of the bone that's broken. So I'm going to go down. There are two joints involved in your ankle. You have the ankle joint and the syndesmosis joint. I think I said that right. Close, close, good. So where the tib, fib, and the talus meet. All right, and then the joint between the tibia and the fibula, which is held together by ligaments. Multiple ligaments actually hold together your ankle. So that's why there's lots of ankle sprains and strains and those kind of things, because ligaments and tendons can be torn easily at the ankle joint. Just a decent picture of the tib fib coming down, and the medial malleolus, which is your inside of your ankle, and the lateral, which is the outside of your ankle. And then there's the joint between the two of them. And that actually has a picture. There will definitely be swelling noted, deformity should be noted, and will probably be noted. pain or tenderness to that area, when they present to you, you're going to know, I twisted my ankle and say, okay, so if you say you twisted your ankle, then I'm going to splint that ankle. I'm going to put ice pack on that ankle to reduce the swelling, and we're going to transport that patient to the hospital. If they're not coming POV and they're coming by us, by EMS, then that's what we're going to do. The key to this whole thing is splinting it. It's very important because we need to make sure we got good pulses, splint it, and we still got good pulses. All right, if you're taking a pulse, if you're having a deformed ankle or broken ankle or a potential fractured ankle, and you have a good pulse, I need you to take a pen out and mark an X on that pulse. That way, when you go and splint it, then you can actually check that X again and make sure there's still a pulse there. It's a really good reminder that you act, and it helps the ER to go, hey, they did check for a pulse, and I can see where they had a pulse. And we're going to check, and they'll say, okay, they do still have a pulse in that same area. So it's a really good play. Ice pack, pain management, paramedic, and of course, if it's an open fracture, we're going to put that in there again. So I really want to stress the antibiotic treatment because we carry it for a reason. So this has a fractured ankle, pretty simple. You can look at the fibula broken on the right side there, and same. And then there's the joint area, how much displacement there is on the other picture on the right side, or stress view, where they actually stressed it. So you understand that take a picture of an ankle, then they may actually take and twist the ankle when they take a second picture to create more of an opening to see if the break is better or worse when it's moved. That's why that picture looks, and when it says stressed view, that means they actually physically twisted that ankle. I'm sure it made that person really happy too. But that happens when they do that. And then this is a pretty decent picture. Seen this picture before. Actually had Dr. Leach one day told some little guys, I'm going to put your foot back on your leg. And so he pulls like this and he pulls it out, twists it like this and put it back on there, and they set it in the cast, and then went to ortho, went to surgery. So, but that's a pretty decent one. So this one's going to get the pain medicine, it's going to get the antibiotics and splinting. Okay. What's most important about this foot is the foot doesn't have a pulse. Because there could be something impinging on the artery, going to the popliteal artery down to the top of the foot. And we want to make sure it's got a good pulse. We want to make sure that blood's getting to the toes. Because if it's not, you get one chance to manually set that place back in position. And if you don't you just splint it where it is and you get in the hospital as quick as you can. If there is no pulse, that is an absolute rapid trauma. That's a rapid transport. We need to get somebody somewhere so we can get a pulse back on that foot. You do not want somebody to lose their foot. I mean, that looks terrible, but that's fixable versus someone losing their foot because we didn't splint it or we splinted it and caused more damage. We don't want that. And then I am a huge, there's Sam splint they spin it around, but I'm a huge fan of a big pillow or blanket as a splint for an ankle. Just wrap it up and tape it. As long as I can see the toes and I got good color and I can see where I put my pulse, that is, if you think about that, top of the foot, you're going to pulse, you can actually see that. And I think it's a really good splint. And I used to use them all the time. I learned that from some other old paramedic guy. I don't know who that was, but I learned from him. So if you're taking care of versus our protocol, so if you have open wounds and bleedings, of course, you're going to dress those wounds with sterile dressings. We're going to control that bleeding if direct pressure, and if necessary, put a tourniquet on it. Years and years ago, tourniquets were taboo. We don't do that. They're going to lose their leg. Now it's one of the very first things you do. Obviously, if you learn and know anything about stop the bleed, that's the first thing you talk about is tourniquet on it. It's easier. It's better to save the life than to save the limb. But and I didn't realize this until I started working in ortho that they'll put a pneumatic tourniquet on something for 90 minutes. And work on it and then let it out, clean up all the bleeders and then put it back on again. So it's not like it can't go for a length of 90 minutes is a long time. We're not even going to have a patient that long. So all we need is put a tourniquet on and let them deal with it, right? Then we stop the bleeding and fix the problem. It's for them. It's on their responsibility. So dislocations and fractures, you want to treat all possible dislocations like fractures, which means everything gets splinted. I have said that a lot, but there's a reason for that. Stabilization of everything we do in the field from the hips down will save so many problems and create less injuries for our patients than what they have when we brought them in. If something's free flopping like this and we're driving to the hospital and it's moving, the chance of doing more damage is so high, it's not even funny. So splinting is important. Consider vascular compromise and internal bleeding. Like Matt was mentioning something about it's either the hip, the femur, or intra-abdominal problems. So it's there. Assess for distal perfusion, splint in place, or position of comfort. If you do not have pulses, you get one attempt at manual traction to regain that distal pulse. If it's there, splint it where you did it the second time. Take a pulse and there's no pulse, move that splint, the extremity, put it where it needs to go, and then move from there. Always, always, always continually reassess that distal circulation and motor sensory. That CMS is so important. I need to be able to tell them he had CMS when I got there, he has CMS now. And I did all this work and he still has what I need, okay? Ice packs are swelling. Please do not put that directly on the skin. It will mess up the skin integrity, it can, but more importantly, it will reduce the swelling, and that's the biggest thing we can do. And then, unstable pelvis, it talks about stabilization with the pelvic strap. We talked about that, or the sheet, whatever's necessary. Femur fractures, traction, stable splint of the approved traction device. Bilateral femur fractures may require utility of a long spine board. And that is specifically just so that you have something to put the traction splints on, okay? And then open fractures, I put it down here, that administration of cefalozin for open fractures, you mix that in 100 bags of normal saline over 3 to 5 minutes. Do not administer under 3 minutes. So it needs to be that length of time, okay? And so you have an adult that's over 120 kilos, they get 2 grams. If they're less than 120, they get 3 grams. And if they're pediatric, they're going to get 30 milligrams per kilogram. Understand those kids are going to burn that medicine up. Their metabolism way faster than any of ours. So that's why there's so much weight base that they're going to burn up their medicine faster than anything else. So always keep that in mind. Here's some references of some information that I got. All right, so there's a couple things I wanted to tell you. Matt Malama, do you have anything that you would like to mention before I move on to my other stuff?
No, I think you covered most of the key points here, and I really appreciate everything you did, Barry. Thanks so much.
Dr. Lynch, do you have anything you'd like to add?
I thought it was a great presentation, Barry.
Okay, good. Okay. Anybody got anything, any questions or anything at all? All right. So for everybody to know, there will not be auto review in October. So as of right now, we're not doing anything on the odd months at regional until whatever they figure out they're going to do. So right now, but there will not be one in October. I'm going to be at the EMS World Expo in Orlando. So I will be leaving that early that morning on Tuesday, and I won't be here. We're not going to do it. So we'll do one in December. I believe Dr. Malama is going to do a presentation in December. He's got some things he's really been wanting to talk to you guys about. Please be sure to email me to tell me you were on Zoom. Okay. I will get the note, but just tell me. But here's something else I want you to do. And this is going to be required coming in December. There's a link and a QR code. There's a quiz on the end of this. If you want credit for the audit review, you need to go out there. This one's really easy. This is just a sample. I just played with this. We can do that. And what this is like, one of the questions is your name. One of the questions is your service. One of the questions is your email. And then there's the 3 or 4 questions based on my presentation. You could answer the questions without even been listening to me talk. But starting in December, this will be able to be seen up on audit review on the YouTube page. If you're live, I still want you to take this. If you're on Zoom right now, please click on the link or do the QR code. Fill out the quiz and send it to me. I want to make sure that I can get everybody's responses, because starting in December, the only way you're going to get credit for auto review is if I have you on saying that you took this quiz. The quiz is going to be a little bit different on the one in December. It's going to be specific to the presentation, not just random questions about lower extremity injuries and things. I just put that in there. I was practicing. I want to see how this works. I trust you guys, but I don't. Anyway, so the thought process is very simple. I want for everybody from now on in December, we're going to take the quiz, and then you're going to get credit for auto review that way. You'll get your 2 hours. I'll be glad to sign anything off at that point in time once I see that you're named on the list. So that was, now drop this down, I think. Yeah, okay. I'll put this back on actually so that it'll be up there for you. You guys have any questions at all? Anybody have any questions online?
Barry, you can't click that link because we don't have access to your page.
Can you do the QR code?
I mean, I could and I can do it later.
Yeah.
I can't click anything on the
Okay,
screen.
so I may have to just not do the link next time. It just may be the QR code only. So.
You doing it? Go ahead.
You
Barry.
drop the.
If you copy that in your comments for your Union Hospital, the YouTube page.
Okay, I can put the link up that way. Yeah. All right. I'll somehow make sure the links are up there in the comment section, so you guys can click on the link or do. Thanks, Dr. Lynn. All right. If nobody else has anything else, I'm gonna mute. I can leave this on for a little bit longer if you need me to. Otherwise, I'm going to stop sharing, and this will adjourn the meeting. Thanks, guys, for your time. I truly appreciate it.
Just use the camera app and then zoom in.